Over 2.5 million people a year are inflicted with the diagnosis of carpal tunnel syndrome. To understand this diagnosis in better detail, it's important to understand a little of the anatomy in the wrist. The carpal tunnel is a tunnel deep in the wrist here that's made up of the floor of the tunnel is made up of the back of the bones of the wrist. Across that tunnel is a ligament called the transverse carpal ligament, which we'll talk about when we talk about the surgery for this condition. But with technology today, there's increased use of the fingers flexing through that tunnel that leads to a development of inflammation on the tendons. Within that tight, unyielding space, the inflammation puts pressure on the median nerve, which is a nerve that goes through the tunnel out to the fingers of the hand. From repetitive use with daily activities, with increased computer use, with BlackBerries, etc., our technology has made this a more common occurrence. To discuss a little of the diagnosis of carpal tunnel syndrome, the subjective complaints, or when a patient comes into my office, one of the first things they talk about is that they have numbness and tingling, more commonly awakening them at night. Commonly it occurs because the nerve goes to these 4 digits. It's mainly these 4 digits excluding the little finger. They also, with more pronounced symptoms, may get actually loss of feeling in their hand and actual motor loss of the muscles that allow the thumb to oppose to the digits, resulting in clumsiness with buttoning clothes, using a pen for writing, etc. Under examination, the patient, we tap over the nerve at the tunnel, the median nerve. And if that causes tingling within the fingers, that's suggestive of the diagnosis. We also ask the patients to flex their wrists, leading to increased pressure within the carpal tunnel, which is called a Phelan's test. So that reproduces what happens at night when you're sleeping. You tend to sleep in a fetal position, the wrist drawn up, which causes increased pressure within the carpal tunnel. Also, we do a full sensory and motor exam to see if there's loss of feeling and any loss of strength within the thumb muscles. So once we have a proper diagnosis of carpal tunnel syndrome, now it's important to talk about treatment. Treatment, in most cases, with conservative treatment, the symptoms will go away. In severe cases, though, surgery may be necessary. For the conservative treatment, wearing a wrist brace at night when you're sleeping to prevent flexion of the wrist is important. That's the #1 treatment. Also, resting the wrist and the fingers, ergonomically looking at the workstation at work if they're a typist, or adjusting the string tension if they're a guitar player, etc. Anti-inflammatory medication. In some cases, a cortisone shot into the carpal tunnel may also reduce swelling. In more severe cases, though, surgery may be necessary. Now, with the advent of endoscopic carpal tunnel release, surgery is highly effective, but with minimal scarring and a very quick return to work. We do a 10-minute outpatient surgical procedure that involves a 1.5 centimeter incision across the crease of the wrist, and the pain and the recovery, the pain is lessened significantly compared to the old-fashioned open procedure, which involved a very lengthy scar across the palm. Now I have patients returning to full work within a month after surgery. So it's highly effective and much less pain than the standard open procedure. Now we'll start with a skin incision. I'm going to complete the cut proximal. And now I have a U-shaped distal-based flap that we're going to now place a small skin hook on that will essentially be my guide into the carpal tunnel. Forceps, please. Right here. Now I'm going to open approximately 2 centimeters of the antebrachial fascia at the volar midline of the distal forearm, proximal. That'll help facilitate the scope placement into the carpal tunnel. Now we'll take the spatula and I'm going to run this into the carpal tunnel. I'm going to scrape the undersurface of the transverse carpal ligament just to make sure there's no tenosynovium or lining of the tendons that's adherent to the undersurface of where I'm going to be dividing the transverse carpal ligament. So now we're going into the carpal tunnel. You can see the transverse carpal ligament fibers. Right there. You can see I'm pushing beyond the transverse carpal ligament, beyond the carpal tunnel. Now I'm going to engage the blade, you see right there. And I'm going to cut not go all the way to the very end, I'm going to cut the distal fibers here, partially. You see the partial cut there. Now the two edges you can see are still intact there, so you got to, if you see those within the viewing surface of or within the video monitor, then you haven't, and it's a V-shaped configuration there, you haven't completely transected it. A little fat on the, there we go. So we're going to complete the transection proximal. Go all the way, but not to the very edge proximal. We'll come back and do that with our scissors. Distal. Now we're going to run the radial column of the transverse carpal ligament all the way proximal, showing complete division except what we're going to complete proximal with our scissors on the way out. And then there's the ulnar column. Again, you don't see the two edges within the view of the scope at any point. All right, so that's open all the way down, and we're going to inspect the median nerve now. You can, through this field, look at the nerve and make sure there's no masses within the carpal tunnel. That's the nerve there. And it's intact after the procedure, which is important, obviously. Okay, come on out. Now we're going to just apply some pressure to the incision, and we're going to let the tourniquet down now. Tourniquet down, please. It's usually with direct pressure for about 5 minutes is all that's needed to stop any oozing before closing the wound. You can see the fingers pinking up now, all of them, and the palm. And I'll just liberally apply some Dermabond skin glue. Dressing, please. Put a little sponge with a Tegaderm dressing over it so they can start showering right away. And now they can apply ice post-operatively along with elevation to minimize swelling, and can start range of motion of the hand and wrist within the first 24 hours. This procedure, as you can see, involved a very small incision through a minimally invasive approach, as you can see from her left wrist done 3 months ago. With this latest technology, we are now able to bring life back to her hands.